Good morning, everyone. It's 9:30. Welcome back and welcome in the second session of the Ventinova. Yesterday we discussed the ventilation and the keycut and the tube. I come back to that after our introduction. And today we introduce FCV, flow-controlled ventilation, in combination with our Evone and in combination with traditional tubing. And just to do non-protective ventilation. So yesterday we discussed small lumen ventilation, and today we discuss no protective ventilation. Just to give a summary of yesterday. Yesterday we discussed the tube. It's very small tubing, only 2.4 millimeters in a diameter, with pressure measurement and cuffed. Very important. Oh, quick add. This is the cannot intubate, cannot ventilate device. And of course, the ventrain, our manual device to ventilate through very small bore tubings, also in emergency situations, but also for ENT operations. But today, we're going to discuss the Evone. This is our mechanical ventilator, and this is also a controlled expiration. So also with the Evone, we can control the expiration, and this gives us a lot of benefits. My name is Marco Klaas. I'm the clinical specialist and trainer of Ventinova, and I'm going to give you some information about these devices and what you can do with it. First of all, to compare with conventional machines, the Evone is a totally different ventilation device than you conventional are used with. So you have to come out of the comfort zone to understand FCV and the working principles of the Evone. Because we have a controlled expiration, that gives a lot of other opportunities than, for instance, for human controlled ventilation or pressure controlled ventilation. And as you look at the first curves, this is the pressure curve with FCV. You see the linear pressure rising until peak, and thereby immediately it goes over in the expiration by a decreasing of our pressure to peak. So you see there are no pause times, and there is no pressure drop in the expiration. If you see VCV and you see PCV, you see that pressure drops at the end of the inspiration, and the exhaust valve also goes open in the conventional machines, and immediately the air will go out and you get pressure swings. And this is not possible with FCV because you control the expiration, you help the diaphragm to go back to its normal position. And surely with very severe lung injured patients, you can have very excessive expirations, and FCV can protect this very excessive expirations. But also because the Evone sucks the air out, it can also help to suck the air out and thereby have another EA ratio, 1:1. So you don't have to wait until the expiration is finished, but you can ventilate in an E ratio 1:1. And that is the most physical way in our understandings. Then we have the flow. You see we have a linear flow in the inspiration, but also a linear flow in the expiration, which gives a lot of benefits. And then you see, compared to VCV and PCV, the flow is going back to the baseline in a totally different way. And you can understand if patients are very long ill and they have low compliances or high resistances, the passive expiration will be very different in these patients. But in FCV, we have a very continuous flow also in the expiration. When you look to the volume curve, you will see the volume is rising to the top, and also goes very to zero in a very easy, smooth way. So if you compare FCV with VCV, you see, especially in the expiration, not those pressure drops. And I compare it always with an old car. What you see here, when you have an old car and you put on the gas and you give gas, it's a very old car. It can break, and you have to use a lot of energy, especially when you abrupt stopping and then put again on the gas, and then stopping and put again on the gas. And you can imagine this causes a lot of energy and also can break the car. So how do the curves look like on the Evone? These are the curves you see on the display of Evone. You see the, sorry, you don't see the flow on the Evone, but I just to show you how it works. The flow, inspiration is linear, and the expiration is also linear. And then you see the pressure curves, and you can see that on the Evone. I showed it afterwards in real time. You see the pressure rising till peak, and you see then the pressure goes down to PEEP, you call it. We call it EEP, but in conventional you call it PEEP, the end expiratory pressures. And when you see, you don't see any pause times. There is continuously flow. There's continuously flow in the inspiration, but also in the expiration. So you see this sort of pressure curves. And also what is very nice compared to conventional, we have a lot of buttons where you can adjust a lot of things, which maybe not could interfere with each other. Here are only 5 buttons. And to use the Evone is very easy, but you have to understand the physics of the lungs. The first button is the FiO2, 35% in this case, but that's depending, just like conventional, on the saturation, for instance, and your arterial O2. But then it's very different. We are used, for instance, for volume control, to set up a frequency, to set up a volume, and not to have a flow. And the flow is depending on the physics of the patient in volume control. But here you can set a flow on the Evone. So that means if you set a flow of 10 liters, that necessarily means if you ventilate with an EA ratio 1:1, that necessarily means that you always have a minute volume of 5 liters. So that's very important. So you can adjust the minute volume by set up the flow. And you use normally EA ratio of 1:1. And we don't change this because this is the most physical way of ventilating. And as you see during this presentation, we are very careful of non-protective ventilation. We believe in low flows, we believe in low frequencies, and only pressure to open the alveoli and to not to give too much energy to the total respiratory system. Then we have our driving pressure, our peak, and our EEP. You see, we have now a driving pressure of 12 in this case, our peak and our PEEP. And this is causing the tidal volume. So if I higher up my driving pressure, my tidal volume will rise, but it will not higher up my minute volume. That's depending on the flow. So if you need higher tidal volumes, you set up your driving pressure, and just to overcome your alveolar dead or your dead space, to have enough tidal volume, but your minute volume you can do it by flow. So you get this kind of, when you change the settings, you get this kind of treatment. This is what I explained. But if you higher up your flow, you see I higher up the flow from 10 till 15, you get a minute volume will rise until 7.5. And that's depending on your CO2 and your acid base. But if I higher up my flow, depending on the compliance and the resistance of the patients, my peak pressure will be reached earlier. So when with the same flow, my peak pressure is rising earlier, it necessarily means that my frequency will go up. So my frequency is the parameter which is not set. I can change my frequency with highering my flow or lowering my flow, but it necessarily also means my minute volume will change. And when I do that with my driving pressure, when I higher up my peak, for instance, with the same flow, my peak pressure will be reached later. So then the expiration is some later, and my frequency will go down. And as I said, we like to have a frequency as low as possible. But of course, you have to react on your CO2, you have to react on your acid base. But just to be lung protective, we like a frequency as low as possible, and also a flow as low as possible. Because we all know when you have a flow, when you higher up your flow and air is looking always the way of the less resistance, how higher the flow, how more the air will go to the more aerated lung parts. But I explain that with another slide. For instance, with these slides. First, why we think FCV is non-protective, and that when you compare that with a Red Bull, with a can, if you give very smooth pressures, very low pressures continuously on the can will go back to its normal position, and there will no harm to the can. But if you do that 1, 2, 3 times in a very firm way, the can will go back, will break, and will not go back to this normal position. And that's also with the lungs. The lungs are very viscoelastic, and they will break, and you have damage for the rest of the time. And if you compare that with chewing gum, for instance, if you stretch a chewing gum very slow, it will go to a long extent. But if you do that very quick, the chewing gum will immediately break. And that you can compare with shear stress or strain. And if you put it on for instance, a CT scan, you will see if you have high flows, they will go to the upper lung parts. We are used to ventilate with 6 milliliters of ideal body weight in RDS patients, and we say, okay, the 6 milliliters are good to protect the lungs. But if you see this picture and you can imagine the air is going to only the aerated lung parts, you ventilate those parts with much more than 6 milliliters of ideal body weight. This 1/3 is only ventilated, so that could mean you ventilate these parts with 80 milliliter ideal body weight. And when you try to get the air to the lower lung parts, and you do that very slow, that necessarily also means that you can have higher tidal volumes. So that's the balance we try to reach. And if you see this picture, and this picture I mean, you see the shear stress, compressional stress, and all those sort of stresses are related to lungs. And if you see this picture, this CT scan, and you see the atelectasis in dependent lung parts, and you look at the alveoli, schematic near the photo, you see some in the lower lung parts, the alveoli will not go open with the same pressure, but the upper lung parts, the alveoli will hyperinflate, they will go in a bigger extent. So on those borders, on those will be shear stress. And if you do that in a very smooth way and you try to get the whole lung in a normal flow, in a normal velocity, it will be surely much better for the lungs. And to make it more difficult, if you have inhomogeneous lung parts and you put some pressure and some volume to that parts, the air will go to less resistance. That means that some alveolus can go in hyperinflation, some parts are doing nothing, and some parts have a longer time for exhalation. For instance, on the left side, the alveoli on the left side with a lot of obstructive problems, the air will go out very difficult. And there's a totally different situation than the right. So with all these conditions, we have to react on all those conditions. And the only way to do that is to have low flows, to treat the patient very gently. So we also don't believe in false protocols. We believe in very patient-tailored ventilation. No one is the same, and every lung is different. And when you look to the dynamic CT scans for healthy pigs in this case, but if you look to the left side on FCV and then you look to VCV, you see more aerated lung tissue in the lower lung parts, in the dependent lung parts. And this is also very interesting. If you look at the CT scan, you see on the left side is PCV, on the right side is FCV. When you look to the lower lung parts, you will continuously see gray and black areas in the dependent lung parts. That means the alveoli go open, there is aeration in the lungs, and then they go back in collapse. And in FCV, you see that it's much less than in PCV. So the dynamics of the alveoli are much smoother. And then, but at last, how do you use FCV? When do you use FCV? You only can use FCV when patients are not triggered. But that doesn't matter, because if we use FCV as a very long protective ventilation, we also think that patients can harm themselves by patient. We call it, for instance, patient self-inflicted lung injury. But if patients are breathing in a very high extent and use very high tidal volumes in the beginning of the illness, of severe lung injury, and they get very high tidal volumes by themselves because they have oxygen, too less oxygen, they can harm themselves to have too much tidal volumes. And then maybe it's good to sedate the patient, even to paralyze the patient, and ventilate in a very smooth way. And you can see that in the PF ratio. Yeah, the oxygen compared to your arterial, the FU2 compared with your arterial oxygen. So then I go over to the practical training. I will change from camera, and then I show you how Evone works in real time. So this is Evone. You see this green, we have two modes, the jet mode and the FCV mode, flow controlled ventilation mode. I don't discuss the jet mode because this is for operation purposes. But you see the buttons, only the 5 buttons beneath. The oxygen, the flow, the EA ratio, the peak, and the PEEP. Now I'm gonna, connected the Evone to the artificial lungs. So I have artificial lungs which are very low compliance. You can see that in these two parameters. We have the resistance and we have the compliance. So I start them up now, and you see the pressure is rising. This is the first. Now the pressure is going from deep till peak and back. You see continuously there is flow. But now depend, because they have very low compliance, my peak pressure is reached earlier. So to get a higher tidal volume, I rise my driving pressure. That I will go to 20, and that necessarily means that my tidal volume will rise. I now only have a tidal volume of 260, but also my frequency will go down. Because with the same flow, my peak pressure is reached later. You see, I have more tidal volume in this case, and my frequency will go to 14 or 15. So this is the way the Evone works. You see, we have a reasonable low resistance, only 2.3, but we have a very low compliance. If you think normal compliances are around about 50, 60, but also depending on the belly, on the thoracic cage. So that's all causing low compliance. So it's not only lung compliances we have to overcome, we have also to overcome the stiffness of the thoracic cage or the thickness of the belly, the abdominal pressure. So now you see we have a tidal volume of 570, and we hope the lung parts will be more aerated. We have a very slow recruitment. But there's a different case, and I show you that, and I have to change the camera in some extent. So this is the working with no resistance. Now we see the Evone. You see the artificial lungs, and I attach a manometer just before the artificial lungs. And you see the pressure I set up in the Evone, the peak pressure, I make it 20 to make it more easy. My peak pressure is 15. And if you look at the manometer will also go from 5 till 20, more or less. But this is but not resistance. If you have resistance in your airways, the Evone will need pressure to overcome that resistance. So the pressure in the lungs are much lower, and also thereby the driving pressure is lower than we measure on the Evone. Because you can imagine, if you have to get air to the lungs, the pressure in the machine must always be higher than the alveolar pressure, otherwise there is no going flow from the ventilator to the patient. On the other side, when the Evone sucks the air out from the patient to the environment, the pressure in the alveoli must be higher than tracheal. And normally it could be the same if you don't have any resistance in your higher respiratory system. But if you have a higher resistance, and I'm going to show that now, then the driving pressure on your machine is totally different than your alveolar driving pressure. And I can show you that by using two resistors. This is the resistor, a very small resistor you see. This is each lower resistor. And I'm going to test that just before the artificial lock. So the left side is different than the right side, but both have a resistor now built in. And I measure now the pressure behind the resistors. I measured it just before the artificial lock. And then I'm going to ventilate again, and you see what it's going to happen. First, we had a reasonable tidal volume, and we had a low frequency. And now I put the resistors between the ventilator and the artificial lungs. My frequency immediately will go up, and my tidal volume immediately will rise. So much does resistance have impact on the way of ventilating. So all the pressure I do in the Evone is not going to the lungs, but just to overcome my airway resistance. And if I show my manometer, you see the pressures which are going to the lungs are totally different than the pressures I set up in the Evone. So my difference between my peak pressure and my edge pressure is much lower. So I'm ventilating on alveolar level with much lower driving pressure. But this is only in case when I have a higher resistance. I have now a resistance of 16.1, and that is reasonably high. But if I change from lung, one I have the low resistor, now I measure only the left one. So the left lung has almost non-driving pressure because of the high resistor. There's a very high resistor, so in the left lung is happening nothing. In the right lung, there is more driving pressure because there my resistance is lower. So it's always also dependent on which part of the lung has a high resistance. And we only can measure the mean pressures in the machine. But on alveolar level, the pressure or in the lower respiratory system, the pressures are totally different. And now I do them both, then you get another pressure. So that's the impact of resistance on ventilation. And if you don't have don't have enough driving pressure on alveolar level, that necessarily means you ventilate less, and that thereby you maybe have too less ventilation to get your CO2 level okay. But this is also nice. If I explained how lower the flow, how less airway resistance is. If I lower my flow now, you will see my frequency will go down because my airway resistance is also changing. And that you can see on my airway resistance. We get a better alveolar ventilation by lowering the flow, and that's not very, it's not common. We don't think like in this way. Normally we think if we higher up the flow, the air will go more to the alveoli. But you see how lower my flow is, how lower my airway resistance is and how better my alveolar driving pressure is. It's very important to show, because that's the principles, the physics of ventilation. So this. Okay, I'm gonna stop now because it's almost time. Maybe there are some questions right now to answer. You can use the chat. I hope it was a little bit explainable. Surely the driving pressure on a machine could be very different than in cases of high resistance, very different than the alveolar driving pressure. And you see that in the Evone, because we have a very accurate measurement also, very a tracheal measurement, which is measured deep in the endotracheal tubing. And because we have continuously flows, our pressure are very good measured. And if you see for instance, the PV loops, you can see the PV loops are totally different than conventional. If you see the PV loop on the right, you see the PV loop from FCV. And you see in the expiration the volume and pressure comparison are more or less the same than the inspiration. And if you look on the left side, you see in the inhalation, you see the volume rising, and then you see first the pressure drop, and then the volume goes out. And that is what we try to avoid, because that you can call dissipated energy. Energy put on the respiratory system, which not have any function, and only can harm the lungs. So this is more or less my story. Maybe there are some questions, Luc? Are there some questions?
Not until now.
Okay. Then I have to I have to stop. I hope you have a nice day, and yeah, maybe you get sometimes you use the Evone and you get used to it, and you have to come out of to your comfort zone, because it's a totally different way of ventilating, but very explainable if you look at the physics. So have a nice day, and I hope we see each other in the future again. Thank you very much.